they are actually doing this. All right. Okay, so my name is Camilo Castillo. I'm a rehab physician. I've been doing this for about a long time. I'm originally from Colombia, South America. When people ask me where I'm from, I usually say I'm from the deep south, because every time I say I'm from Colombia, people think it's Colombia, South Carolina. So now I say just the deep south. Usually, my function here as I'm being a physiatrist for a long time. I trained in VCU, Virginia Commonwealth University, in Richmond, Virginia. I did an internship in surgery, and then later on, I went to Richmond to do PM&R for 3 years, and then spinal cord injury for 1 year extra. And then I went to Georgetown in Washington, D.C. I worked at Georgetown for about 4 years, and then I moved to Louisville, Kentucky, where I became the director of the Spinal Cord Program and also a professor. I've done research. My passion is spinal cord injury. One of the issues you're going to learn from me in this talk is and this is what I want to present to students and residents, is because it's a very, very small, it's a niche, but we need more doctors to take care of these patients. So my advocacy for these patients, for this field, is stronger now because we don't have enough physiatrists who do this. Physiatry is very small field, about 15,000, 16,000 people in the United States. For us, for spinal cord injuries, even smaller. We're about 480. We're supposed to be more than that, but people are either retiring or leaving the field. So for me, in this talk, I usually talk about primary care spinal cord injury, which is target to you. Now, let me know if the slide don't move. Do they move?
Yes.
Yes. Okay. So I'm a scientific advisor for a technology company in Nashville, Tennessee, and also board member of ASIA, which is the Spinal Cord Injury Association in the United States. And I'm also a member of several boards here in Louisville. My objective is to describe the basic spinal cord injury for you, the outline function outcomes in spinal cord injury, describe the factors affecting the outcomes, and also the importance of primary care in these patients, which is what you guys are going to learn. So I don't know how much you guys know about the anatomy of spinal cord injury. I usually explain to my residents the spinal cord, the high with their body. You have the cross sections, all the details with tracts that go from the brain to the spine, and also the motor tracts and sensory tracts. Obviously, those are the tracts that get involved. The most common ones that we teach are the corticospinal tract, the spinothalamic tract. Those are the ones we teach the most. Those are the tracts that are going to be affected during the injury. Depends of the injury where it happens. Obviously, you're going to be labeled that patients with at the level, which is you have cervical anatomy, you have the thoracic anatomy, you have the lumbar anatomy, and the sacral anatomy. For terminology, people who are injured in the neck, it's called tetraplegia. You're going to hear the term quadriplegia. Quadriplegia used to be, still, a lot of people still use it. People who are in the field use tetra, which means four, cuatro. For tetraplegia, quadriplegia, both significant cuatro. The difference is one was a Latin root, the other one was Greek, so they decided to change it years ago. I don't know why, but they did. And then for chest down, thoracic injuries, it would be paraplegia, chest down. So you have high-level injuries, which would be from cervical high and cervical low to C7, and you have para-high, which is thoracic one to para-low, which are these lower sacral injuries. So those are the most important thing you need to know. Any injury in the tracts. Do you see my arrow? Okay. I know some of the injuries are going to be in the tracts. It going to depends of where the injury happens, and we're going to talk about that a little bit. So the most important tract at this, like I said, the spinothalamic, the corticospinal tract, which is the motor tracts, and also the sensory tracts. But these tracts here, these tracts are the most important where probably carry 90% of the motor ones, but you have about 10% here. So if you have a little bit here after spinal cord injury, you still can have functional gains. Now, people think that spinal cord injury is a transection of the spinal cord. I rarely see transections. That usually doesn't exist. What you see is more like I call it like a bruise. They start to getting bigger and bigger and bigger. And I'm going to show you some stuff like that. And whatever is in the middle of that injury is going to cause problems. Now, one of the things I want to talk about is I'm going to give you a broad summary of spinal cord injury in general, then talk about primary care after that. So obviously, the spinal cord leads to all the system to not respond to the internal external stimuli. It's a functional degradation, right? So we call it the fermentation. It's a huge disruption of the supraspinal regulatory fiber I just talked to. And that can lead to aromatic failure. So your heart is innervated up to T5 to T6. You have sympathetic and parasympathetic function. The sympathetics are the one mainly leading to cardiovascular deficit and leading to a lot of morbidities and mortality. This time around, we have much more understanding. One of the guys who know a lot about this is Dr. Andrei Korsakov. This is in Canada. Recently, there's a young guy in Mayo, Dr. Somlinsky, who is also talking about a lot of research in cardiovascular regulation, including AD, which is aromatid dysreflexia. But this is a big deal for us because after the cardiovascular disruption, patients present with severe hypotension and bradycardia during the acute phase. And that is called spinal shock, and that is usually the loss of tone or the loss of receptors in the spine. And then you have the consequences of the spinal cord having spinal shock, where patients are basically flaccid. During that time, you're also going to have the shock related to the vessels. You have a huge vasodilation with hypotension and bradycardia, and that has to be managed acutely. And that makes a huge difference when it comes to regulation of the spinal cord. When we talk about simple problems in the spinal cord, not just the cardiovascular, we have plenty. This is a menu of things that we see as a physiatrist related to spinal cord. Some of the things that we do, obviously for spinal cord injury, depending on the level, you have high cervical injuries, which can cause a lot of problems. People who are above C3 usually have difficulty with bent weaning, and most people will not be able to do that. Most patients are able to be weaned off the vent, but it all depends on the injury level. You also have GI system interruptions, nutrition, bowel, bladder, DVT prophylaxis big, skin issues huge. So we want to talk about many of this. HO, spasticity, AD, hypercalcemia, and the rest. This is what we do as a physiatrist. I'm not sure how all of you are interested in physiatry, your interest, but we overlap with many specialties, including urology. And the VA, for instance, considers spinal cord injury doctors as primary care physicians for their patients. Facts and figures is important because this is your basic data about spinal cord injury. This is released from University of Alabama, from the model system. Facts and figure, they're been around since 1973. It's basically all the data that we have from all the research around the United States. Model system is a very prestigious assignment that hospitals have. We used to have it in 2016. It's very competitive, and it goes to do research, collaborative research to help understand the spinal cord injury and data. You have a lot of data points, captures about 13% of all new spinal cord injuries, is longitudinal, so it's from the time of the injury until they basically die. So it's pretty good. So it tells a lot about, for instance, the prevalence. Like I said, it's about, it changed throughout the years. But in general, acute injuries, it would be about 18,000 actually, 18,000. Gender, usually young people about 40s. Gender, usually males, because we do more stupid things than females. Race, we have that because obviously Caucasians, minorities also a big part of it. Causes, United States, most likely motor vehicle accidents is the most common one. Then you have falls and elderly patients. You also have violent sports, etc. The length of stay relates to the fact that as a spinal cord injury pathology, you can imagine that this disease is so devastating, people stay in the hospital for a long time. That used to happen, that doesn't happen anymore. Length of stay for patients spinal cord injury and acute care probably could be a week or two. And then rehabilitation used to be months, now it's weeks. Now, when you travel, if you travel ever in around the United States and Canada and Europe, even Latin America, like I do, you will see different diversity of admissions. And this is internationally. Canadians keep their patients in rehab for longer than we do. The same with Europeans. And Latin Americans is all over the place. They have people who stay months with people who go home. Like in Colombia, where I'm from, people get injured with spinal cord injury, and they don't have spinal cord units in Colombia, for instance. So they get injured, and the patient basically go home from there. No chair, no cushion, no nothing. So the patient get out of the hospital with the rehab done inside the hospital. In the United States, how it works is, I'm sure if you are rotating in units like ours, patient get injured, goes to acute care, and then comes here to rehab. And that's about, complete rehab is about 4 to 6 weeks, depends on the level of injuries. If it's a paraplegia, it would be about 2 weeks. If it's a tetraplegia, it would be 4 weeks. Some hospital, like in Texas here or in Atlanta, Georgia, like Shepherd, they have a different assignation, so they keep the patient a little longer. The same with Craig and Colorado. But we are acute rehab unit, so we go by insurance and pressures that we have from others. So we keep the patients as much as we can. But usually it's about 4 weeks. That is never enough. So the patient come back for outpatient and usually stay longer. In other countries, for instance, Europe, they stay for months and months and months. In Korea, they can stay up to a year. And there's a good thing and a bad thing over there, because good thing, you have time to teach the patients everything they need. And when they are ready, the problem is patients are institutionalized. So they don't want to leave the hospital. And that's what one of the doctors in Korea told me. He came here, I didn't go there. He explained to me that sometimes can be a double sword. So it depends how you looked at it. I think we have a system that it can be challenging. It works in some ways, and sometimes it doesn't. So that's what I tell you a little bit the politics of that. Now, the reason I'm telling you this is because this graph, I always like to present this graph because the life expectancy for spinal cord injury remains below the general population. This is from Dr. Kirschbaum's book. This is the book that we all trained. Steve Kirschbaum is one of the leaders in spinal cord injury. He's basically the one who writes the book that we all train. And if you look the graph here from 1973 to 1979 and 2010, 2017, the blue chart that you see here and the red chart, this one is the first year mortality rate, has decreased from 1973 to 2010. And the reason is because we're doing, can you see my, you can see my my thingy, right? Right. So the reason is because we have done a much better job at getting these patients in acute care. Acute injuries, when the patients get injured, the type of hospital they go, the trauma people, the surgery, the early surgeries, all of that have improved tremendously throughout the years. So we captured these patients earlier, right? So the first year injury, along with everything else, because what I just explained to you, they stay here such a period of time. And like DVT prophylaxis is much better than it used to be, managing the respiratory, manage the bladder, skin, all that has improved. So the first year, the mortality rate has increased. But this is the problem. This is why we need more spinal cord doctors. Hint, hint, hint. So because this blue graph hasn't moved much, that means we don't know where they die. basically the mortality after the second year, the fourth year, and later is the same since the 1970s. A little bit better, but not much. So that's the sad part, that because in rural Kentucky, there are not a lot of doctors like me. So patients go to an acute care hospital. The doctor doesn't understand what is AD, right? They try to treat it the best they can with honor and understanding what AD is. And the patient don't understand that maybe the patient have stones or having because you have to have a high level of suspicion in these patients sometimes because they have the afferentation. They have no sensory in many cases. So sometimes they can't recognize complications or they develop pressure injuries and they ended up in a place where they have sepsis and die, which is one of the reasons, one of the causes of death in these patients. So during the lifetime cost care is very expensive. This is a very expensive disease. I do life care planning for patients with micro injury, and this $5 million that you see there, that's nothing. That's nothing. Now that's data from probably old data from the model systems, but I do cases where I have done, life care planning for patients with micro injury go up to 15 million, $20 million, and people have high level injuries, meaning this is what they're going to use. That's the money going to use for the rest of their lives. Because it's a very, very expensive injury. Having said that, rehab works. Most patients go home, like you see there. So people go home usually. The problem is, I always tell patients, you have to have a village. It doesn't have to be a big village. You have to have a village because it requires a lot of assistance. These patients require a lot of care, a lot of assistance, a lot of surveillance. If you don't have that, unfortunately, ended up either in a skilled nursing facility, nursing home, and it's never good. And obviously, the outcomes of these patients depends on how bad the injury is. So if you see here in this chart, on the top top part of the chart, you see the level C1, C4, C5, C6, C7, C8, and T1. And then here, this is the type of function the patients of the outcomes, the functional things the patient has to do: feeding, grooming, upper dress, lower extremity dressing, bathing, and the rest. So depends of the level. If you see here how dependent the patient is, obviously for C1, C4, it's going to be very much dependent 24 hours to do everything. To C8, T1, right? They're mostly going to be independent. And then in between, you have everything in between, right? So a C5, you can see me, right? A C5, basically biceps, C6, extensor, C7, the triceps, C8. So the more distal they have the injury, obviously the more function they're going to have, which is important because a patient who has C5 can feed themselves, right? A patient has C6, they can do something called enodesis. They can grab something with their hands. C7, they can transfer, and that's the highest levels of independence. If you have a C7 patient, you can do a little for yourself. And obviously, the higher the level, obviously, the more dependent they're going to be. Now, this graph is only for patients who are complete. And I'm going to make it more complicated for you. But basically, if you're incomplete patients, that's the difference between, that's the functional difference. If you're a complete patient, and we're going to talk about this in a minute, meaning you have no sensory motor below the level of injury. If you're incomplete, you have something, either sensory or motor. So this graph was designed for people who are the most severe injuries, which are incompletes, okay? So you cannot tell me, for instance, incomplete C5 is not going to be able to feed themselves because that's not true, because it depends of the severity of the injury. So it gets complicated, but in general, factors determining neurological recovery, meaning who's going to do well, is the early and acute neurology exam, which is what they do when their patient arrive, which is the ASHA exam. That's going to be the main thing we're going to do. That tells a lot about the injury. The long-term prognosis, again, like I said, whether the patient is complete or incomplete, whether the patient have sequel-sparing or not sequel-sparing. A complete always going to have more complications. The early examination is important because we know that when they arrive in our hospital, our surgeon, we're the Department of Neurosurgery as well. We worked very close with them. So when the patient arrives, they usually put a consult right away. I ask them to put a consult right away because we can see the patient right after the injury. Even though they are not ready to come here, we helped the team to adapt and to start choosing the right thing for the patient so they can come to our units as soon as possible. Okay, I can hear somebody in the, okay. So there are many, I'm not going to talk about this, but there are many ways of conversion rates in these patients from complete and complete, but I'm not talk about that. So again, like I said, the better outcomes for our patients would be whether or not the injury is lower and how incomplete it is. The more incomplete the injury, the better. The rehab issues you're going to encounter, like mobility, adjustment to disability, communication, ACI education, this is all important, right? We're a holistic specialty. We see beyond the acute care. You have to think about coordination of care. This is why people sometimes get frustrated with us, because we're annoying with, okay, have you done this? Have you done that? Have you done this? Because we don't look only the injury itself. We look everything beyond that. And the lower the injury, the better. The more incomplete the injury, the better, and vice versa. Some of the things that you had to do, a key aspects of pre-hospital admissions, suspecting SCI, you have learned this probably from med school, immobilization, airway, circulation, all that affect hospital management. And remember I told you, because things have changed so dramatically throughout the years as far as acute care, this has changed also the outcome for the patients. So a lot of people survive this disease nowadays. And like I said to my patient, you're gonna see my last slide say that, but I'm gonna say it now. And it's not it's not my statement. The spinal cord injury is not a death sentence, right? It's a new life for these patients, and that's what you have to think about, right? These patients can live, and the person who taught me everything I know about spinal cord injury, he had an injury, and he was able to become a doctor, become a rehab doctor, become a spinal cord injury doctor. So he taught me everything I know, or whatever he knew about spinal cord injury, and Dr. Getz, he's in Virginia. And so I usually tell them, I mean, this can be done. The presence of all the complications they can have, hypovolemic shock, neurogenic shock, all that stuff you need to consider it. But in general, people do well the first time. Now, predictive models for these patients, there are many. We had many. And the main thing you have to learn from this, like I said, whether or not the patient is incomplete or incomplete. Age is a big one. Youth is a wonderful thing. Comorbidities, obesity also affects function. As far as prognosis, the age exam is huge for us. MRIs as well. But in general, the completeness of the patient tells a lot about the injury, but also comorbidities. And this is what's hard. Sometimes people ask me, am I going to walk? And that's a hard question that I have to answer almost every day, because I had to look the whole picture of the patient, the perception. I'm going to show you a slide about functional outcomes as well. This is our main tool that we use for prognosticate. Are you familiar with this? Have you seen the H exam, or called the INSCI exam?
Yeah, I'm in the spinal cord injury rotation right now,
Oh,
so I do
where?
these like every day at Mount Sinai.
Where are you?
In Mount Sinai in New York.
Oh, with Dr. Bryce, Tom Bryce.
Yeah. Hmm.
Yeah. Okay. So yeah, I mean, oh yeah, so yeah. Well, they're a model system, and Dr. Bryce is doing a ton of research with the model system related to using not just this, but also the autonomics, the ISAFSCI, which is the autonomic portion of the ISCI. So this is the motor sensory part of the exam, but we've Dr. Krosakov, which is in Vancouver, described that this is not enough. Doing a motor sensory exam, and you can tell Dr. Bryce, he will agree with you. He will be impressed. It's Dr. Bryce, I don't think this is enough. What about the autonomic function part of the exam? And he will say, oh my gosh, because the autonomic function is as important as the motor function, and it's called the ISAFSCI. ISAFSCI is the autonomic part of the exam. It looks like this. Let me see if I have a copy, I think, right here. Let's see if I have a copy. I don't have a copy in my copy. So the INSCI looks like this. This is the INSCI. I'm sure you have seen it. Ellie. Oh, I can't see it. Right, there you go. And the SAPSCI, I have in my coach, but I'm too lazy to go to now right now. But the SAPSCI is the other one that has been designed to predict. So it divides between sensory and motor. You have a score, and depends on the score, you do first whether or not the patient is complete or incomplete, and then you define the severity. So whether the patient's A, B, C, D, and E. E's are rare. So I haven't seen an E in years. Most people are incomplete, thank God. But completeness can be from C's to D's and also even sensories B's. So those are the ones that you have to look. This exam takes probably, what, an hour? Here in Louisville is done by therapists. And they are trained by Asia. They come we ask them to come every 2 years. Because as a physiatrist, I think that the therapists do a better job than the physicians. That's what I believe. Because they take the time, they close the door, it's 1 hour, no interruption. I can't even go into the room. So they do the exam, they do everything. And we have also, to validate this, we also have meetings every quarter to discuss cases that are difficult. So I think doing it this way, the way we do it, is helpful because it makes it a conversation. It forces everybody to talk about this exam, and it provides a better information. Like I said, this doesn't tell the whole story of the injury, but it's a very good tool for prognostication as far as function. This chart is about initial versus late recovery. And you can see there are different lumps of recovery in patients, for instance, A's, B's, C's, and D's. The HIAs, which is the most severe injury, which means there is no motor sensory below the level of injury, including S4, S5. Those patients usually stay the same. So if you see there on the first graph here, most A's is still the same. If you have A to a C, right here, A to C, so a lot of people convert, and these to these, a lot of these stay the same. This is the graph I'm going to show you, which is a hodgepodge. B's are those who have sensory but not motor below the level of injury, okay? And those are the ones that are hard because according to this data, they can convert, but they are, if you see here, they're all over the place. C's are incomplete motor and sensory, and D are the best prognosis. So A's are going to stay the same. B's is a hodgepodge. You're going to see all over the place. And they have C's and D's, which are the motor function is going to do a better prognosis. Again, to restoration versus compensation, I explain this to my patients all the time. We have to first aim for recovery and then adaptations. And that's what's hard for the patients to understand at times because everybody wants 100%, which I don't blame. But the motor learning, the adaptations, the remaining motor elements, all of that helps. Obviously, rehab helps, as you guys know. So it's important to educate patients about what they're going to do and what kind of tools you're going to use because it's like I call it instrumental learning. And that's the integration that you use to help substitute what they have lost because it's a new learning from the spinal cord, from the nervous system to start using what they have left and to try to adapt for those things that they can't use anymore. So that's the thing. And then the survival is influenced by, obviously, but like I said, by underlying of how healthy the patients are, young, level, and severity. If you have a 60 years old patient, a 70 years old patient who fell in the bathroom, have a tetraplegia, cervical injury, obese, diabetic, develop pressure injury, which we have a lot sometimes here, then your functional outcome is much different than one of you having this injury, the same injury, which it's not going to be a fault. It's going to be probably a motor vehicle accident or a diving accident or gunshot wound. That is going to be, it can influence your outcomes. So health conditions, level, and severity are huge, and you're going to see that a lot. So that's important. And like I said, majority go home. We struggle with this a lot because these days with insurance and cutting, we struggle to trying to get patients to be ready on time. Nobody gets full rehab in the United States, basically. You had to continue doing outpatient. Outpatient can be lengthy. And then in between that, I don't know how they're doing one sign up, but here in Louisville, we have a navigation system. And I will show you my slides at the end as well. So we had nurses who follow the patients after discharge because this is very rural and patients go everywhere. So then when they go after, we used to lose them. We couldn't figure it out. And the navigation system started in New York, actually, with cancer patients, breast cancer. A doctor in the Bronx that actually was losing patients after discharge. They were dying because they were not having follow-ups with him. And he created that, but that was years ago, 1980s. So it was replicated in many specialties except rehab. So we decided to do it on our own, and we have done it. We have done presentations, and it helps. So these patients go home, and then we have close contact with them through our navigators to figure out what they need. And we know when they get in the hospital again. We know when they get go to the ER. We know when they have a baby or any of that, because it helps us to keep the patients healthy. You want these patients functional. That's what you want. Now, the primary care issue for spinal cord injury is not new. This has been proposed years ago. Like I said, the VA, for instance, consider spinal cord doctors as primary care of the spinal cord patients. I disagree that I should be the primary care of my patients, because I honestly don't think I would manage diabetes as well as a primary care doctor. I can manage hypertension. I feel confident about it, but diabetes and other diseases that I'm not trained, and this is a different population. So I struggle with this. What I do is I find primary cares that work with me. And I call the primary cares, I have networks of doctors. I have urologists, I have endocrinologists, and they help me to connect the dots. I have a cardiologist. So they help me with that. Otherwise, I don't feel that we should be the primary care of these patients. Access is being a huge thing. For me, access is huge because these days, particularly with everything that's going on, diversity inclusion is extremely important. And access to our clinics, access to primary cares, access to us, in particular in places like mine. I don't know where people are from in this call. I know you are in New York. Obviously, New York is different. But for people here in Kentucky, it's really hard to get a doctor. Some people who live close to Tennessee, they had to drive 3 hours to see me. And we used to have telehealth, and we still have telehealth. But telehealth is going to go away, and that was huge for us because patients couldn't see us. So I don't know what we're going to do, but that's access, right? So we have a lot of people with lack of transportation, no wheelchair ramps, spaces, mobility aids, and the ability to transfer sometime. We don't have the right accommodations for them when they come to the clinics. So this is a huge topic for us, but it's really hard to change because how medicine is practiced now, you're going to see 40 patients or 30 patients. I don't do that, but in general, for a primary care, they don't have time to put the patient in the table and examine it. They won't do it. So that's the problem that we have these days with all the pressure that we have to slow down and talk to the patients and sit down and listen to them. And that makes you different. That's kind of been lost these days. Some philosopher here, but it's true. Spinal cord, obviously at great risk of exposure of everything else about aging and rapid aging. And that's the other half of my talk, basically. Explain to you what things you see that are different. They have so medical issues that we have to address. Let me drink a little water. The first thing is something that we see a lot in our population, which is bowel and bladder. Used to be a leading cause of death 50 years ago. Now is very low. We understand it better. We know that is one of the main causes of rehospitalization, UTIs. So a lot of people working on this, including people in Mount Sinai, tier where I used to work in Georgetown. They're trying to understand it because there's a process of inflammation. And we believe this part of the problem is how they respond to infections. They don't respond to infections the way you do. So because they lost the ability to control the sphincters and they lost ability with the central nervous system regulatory mechanism, there's a constant process of inflammation, which is what I believe. It's a process, constant inflammation in these patients. How to respond is really hard. Even though I said there management, adequate hydration, hygiene is true, a strict urology follow-up, smoking cessation, all of that is absolutely 100% true. However, it doesn't apply to every patient. I have a kid who was in the hospital every week with the UTIs. We try everything in the book, everything. We try antibiotic, we try infusion, we tried instillation. We asked him to do a colostomy. We thought was the bowel was having problems too. It was a high level injury, and he lived 3 hours away from here. So every time he got sick, they shipped him here to Louisville, which is 3 hours drive. That poor kid was. I told him, "You're gonna die if we don't do something." We ended up removing his bladder about a month ago because we couldn't find any other way for this kid to have control his infection. It was terrible, and the reason the infection was not infection itself was the AD, that anomalous reflexia. He was coming to the ER with blood pressure 200s. So I was every ER every time because they would call me because nobody had to know how to manage it with tremendous amount of spasticity, like crazy, because everything else was reactive due to the bladder. We removed the bladder. Guess what happened? The blood pressure dropped. The spasticity got better, not 100%, but it got better. So yes, it's true, but each patient is individualized. Hydronephrosis and tract titration, this is what you want to prevent. You basically want these patients not to have long-term issues with their urinary tract system. Dyssynergia is extremely common. It's basically simultaneous contraction between the bladder and the sphincter, the bladder wall, the sphincter, sorry. And that happens a lot. And probably this kid was having that as well. And is basically due to the lack of control. Bladder cancer. My first publication ever as a resident, not even as a resident, was a small researcher, was about a patient who had prostate cancer after having indwelling catheter for 15 years at the VA. We don't know for sure the cause, why. The catheters have become better. We think this more related to the cells becoming changing with time, metaplasia, instead of the catheter itself, because the catheter have become, the quality of catheter have become better. In the guidelines, obviously, we prefer patients to have intermediate catheterizations instead of indwelling catheters. But in our guideline, which is done by the VA, there is a role for patients using indwelling catheters. But those are patients who cannot cath, or they had no one who can cath them, or there are no other solutions for them. So we usually like people who wants to intermediate catheterization on somebody who is going to who has to do the intermediate catheterization for them. Having said that, again, like I said, these patients have to have a village. If they don't have anybody, and I have this conversation every day with my patients who qualify, and I do it earlier. And I said, this is a quality of life issues. And guess what? They usually are okay with the bladder management, which I'm going to show you later on the type of, well, here is. So I usually offer them either suprapubic catheter or some type of alternative management when they can, because we know we have enough research showing that the caregivers burn out. And we know also that the rate of divorce in this population is high. You better meet the person after you injure, not before the injury. Because before you meet the person for the injury, 50% they're going to leave you. So it's because of the care. And this is one of the big ones. Catheterization every 4 hours. If the patients are complete or incomplete and can't pee, that's what happens. So every 4 to 6 hours, it's exhausting. So some type of diversion that you see here, Indiana pouch or Mitrofanov, which is the one that most people uses, they are the ones who actually help with quality of life. But the one used the most is the suprapubic catheter. And that's the one that's very quickly to do. Sometimes we do it in the inpatients here when they arrive. If it sees a very high injury, I call the urologist, they do it. And it helps. I tell always the story of one of my patients who had the indwelling catheter for 2 years. And I was arguing with the urologist to take the catheter out. No, 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 no. That was years ago. And I said, you don't understand, this is quite a life issue. I finally convinced them to take the catheter and put a suprapubic catheter. Guess what the patient did the first time he got his catheter out and they put a suprapubic catheter? Remember, the catheter got out the penis and put it in the belly. So the penis is now free. He has sex with his wife. And that's important. And I told that urologist, said, see, that is extremely important. So this is what I said from the beginning. As a physiatrist, we look beyond all those things, right? Everybody does a great job in their field, right? But you have to need that person, that's annoying person, a physiatrist, annoying the person that says, see, you have to see things differently. And that helps with your outcomes. Neurogenic bowels also goes hand to hand with neurogenic bladder because they have similar innervation. They can have from upper GI to lower GI, from GERD to gallstones to colon cancer, which we don't know why, to obviously neurogenic bladder-related constipation, megacolon, fecal incontinence, hemorrhoids, and anything under the sun, anything. So we have a lot of issues with this. These are the huge things that we see all the time. Patients arrive constipated from acute care. We have to clean them up. This is an ongoing issue. And the same thing I explained to you from the standpoint of bladder happens to bowels, right? So these patients basically come and they have to do what we call the bowel program, which basically is putting, I'm sure you have seen that, Eli and Mount Sinai, which is a bowel program which requires suppository, requires rectal stimulation. And if they have a lower motor neuron, which is below where the spinal cord injury ends about L2, then you have to do this impaction, and that's not fun, right? So think about intermittent catheterization every 4 to 6 hours, along with the funny part of doing rectal stimulation, positioning, and all of the above. So when I mention to severe patients that my advice is to do a colostomy, they freak out. So it's interesting. Patients are okay with the urine coming out the front, but they are not okay with the poop coming out in the front. And that is always hard to convince people. But guess what? When they have it, they don't want it reversed. They usually notice the advantage because it is an advantage and it is reversible. So you have to tell them that. I'm not advocating by any means that you do this at first, because obviously a lot of people recover their sphincters. Obviously, a lot of people like paraplegics, they are happy with their programs. They can do the program themselves. I'm talking about severe patients or people who stay in the bathroom I just had a patient, they called me this morning, who stayed in the bathroom for 6 hours. I said, that is not normal for a bowel program. So those patients, if you can't figure out what it is, you got to recommend colostomies, because otherwise it's not a quite a life. You can't spend your day in the bathroom. That's ridiculous. So every time they come, this is what we do. We go, everything you're seeing here is what I do every day with my patients in clinic. Now, there's a caveat about spinal cord injury. I know it happened in New York, is that spinal cord injury is cyclical. So most injuries happen, June, May, June, July, August, and it goes down. For instance, this time around, we are very low in spinal cord injuries right now because there are not many at this time. Although places like New York, or places where you have a ski, you see a lot of injuries related to that. Us here is usually rural. Usually in the summertime, we see all the injuries. It's crazy. People going into pools, gunshot wounds, motorcycle accident, etc. So again, all of that is to say that everything you see here is what I do every day with these patients. Cardiovascular system, I talked a little bit about the beginning, is catching up with our patients. The number one cause of death with these patients is respiratory, because majority of these patients, the ones that are most common are tetraplegics, and they're going to have problems with respiratory system. However, excuse me, cardiovascular is catching up. And as they get older and obese, they lose muscle mass. Remember, if you are skinny at the time of the injury and you lose muscle mass, but you also gain fat mass because of lack of mobility. If you don't take care of yourself, or you rehab, or you're not active, and even if you do, many people can control it. So there's a lot of problems. We published an article with Dr. Gator, who died 2 years ago, my mentor, about incidents of patients with metabolic syndrome in the VA hospitals. It was 70%, it was high. And David Gator was the one who actually did a lot to figure out about inflammation, obesity, and how to treat these patients for that, because we were missing a lot of these people. Now we know there's a huge, and we have guidelines now for that. So it's a huge topic nowadays because if you think about it, if you have a patient with spinal cord injury, a tetraplegia, and severe HIA, which is not sensory motor below the level injury is complete, how are you going to recognize they have chest pain, right? So that's also highly suspicious because they are not going to have the same symptoms and the same signs they have for a person like you or me. So that is also important to recognize, okay? Again, we talk about that. Basically, well, we talk about negative fat balance, energy balance. So, how do we prevent it? We basically treat like anybody else, cholesterol, control sugars, encourage activity. But even with all that, still, I struggle with people when they come to my office to talk about obesity because it's a very sensitive topic, and some people tell me that's the only thing I can control, my mouth. There is a researcher in Miami Project. I don't know if you guys are familiar with Miami Project. University of Miami is very huge in the spinal cord injury. Miami Project is a big entity who has leaders. They are leaders in the spinal cord, and they have a researcher there, a young guy who came here, did a lecture for us, and proposed something I didn't think about. And he said, if you guys think about high tetraplegia patients who have neck injuries and more severe patients, they can feed themselves. So the amount of calories they're in the intake is correlates with the person who's feeding them. And I'm gonna tell you, I don't know how many Latinos are here, but if you're Latinos, you're Spinal Cord Injury, you have mom, you're gonna gain weight very fast. Because your mom, tu mamá te va a dar comida hasta no poder. And I have a Cuban boy right now that is exactly what's happening. And my last visit about a week ago, I told mom, you got to stop because he's a young guy and I can see him growing on the sides. And I said, you got to stop. I never thought about that correlation. So he's doing a research study right now. He's proposing grants in the University of Miami to study this and how many calories they need to be fed to not gain weight, which that was an impressive thing. I think about it. So that's kind of cool. So again, these old preventions are cool, but there is not only thing you have to take in consideration. AD, I don't know if you guys know much about AD, but it's a syndrome that happened to our patients for people who are T6 and above. It can go down to T8, but most people are T6 and above, usually complete patients. Incompletes can have it, but less so than complete. It happens usually after spinal shock. So like acute, and then after that, they can have AD. And it's basically, again, it's due to the differentiation and the lack of input to the brain to recognize. T6 is because you have just plaquenix, and below that you have the bowels in the bladder. 90% of the time is bladder, bowel, and skin. So you have the bladder distension who send afferents to the spinal cord, which send information to the vessels and cause the hypertension if you have the distension of the bladder. And then because the brain can recognize it, but you have the system in your neck, the carotids, they can't recognize it, but it doesn't have enough information to cause hypertachycardia, which now we know, thanks to Dr. Solinsky, that it can happen to tachycardia. but usually is hypertension with bradycardia. That's what we teach our residents, but now we know that tachycardia is also possible. It's a deadly situation. You have to figure out why. And like I tell my residents, it's a syndrome. So you have to find out the reason. Again, what I teach my residents is bowel number one, bladder number one, bowel number two, but it can be both, and also skin. In my book, after that, anything else. I have seen hemorrhoids, I've seen nail issues, I've seen fractures, I've seen gallstones, pancreatitis, UTIs, well, UTI bladder. I've seen everything. So it's how sensitive the nervous system, because I do believe, and this is something also very personal, practicing so many years, the presynaptic neurons, they atrophy at the time of the injury, and they never, they come back. They shut down at the beginning. So the presynaptic neurons are shut down at the beginning of the injury, and they atrophy, and they reassume, they come back again, and they start functioning again, but I don't think it's the same. So the C fibers, when you have a distension of the bladder and you have C fiber respond, is different than you have a more systematic response. For these patients. It can be systematic or can be just boom, from 0 to 10. And I can tell you stories about that. Usually I like to lecture people with stories. And one thing that I found, I have a patient last year during Thanksgiving weekend. I was not on call, by the way. And they kept calling me because the guy was going to blood pressure 200. So I asked him to go to a local hospital because I said, this is your bowels causing this. He went to a local hospital. The doctor called me and said, I don't understand why you think that. And I explained why, and they made him have a bowel movement. The blood pressure dropped, went to 100 and whatever. He went home and then called me again at 6 p.m. And I said, you had to go to University Hospital because that hospital is not going to understand what I'm doing. So he went to our hospital here. He got admitted to ICU because his blood pressure was 200. The ICU doctor called me and said, I don't understand what you're doing. I said, try to do bowel program to him. They tried, blood pressure goes. We couldn't even touch it. We couldn't even touch that. The rectum, it will go to 200. So I said, the only way you can save this kid is to do a colostomy. And they did. And the blood pressure went down without of that. Simple things like that. Went down to the ICU and we saved his life. Even the neurosurgeon asked me, they said, how that happened? People don't have that concept. And I said, because if you have a hollow viscous, like the bowel and the bladder, that's exactly what's going to happen. Because when they distend, you have C fibers. And I believe that those presynaptic neurons are never the same. So people won't respond that way because he was doing fine. And at some point, he's just not responding anymore. And then from 0 to 10, his blood pressure went to 200. So again, when you practice for so long, you just recognize patterns. But the bottom line is that make sure these patients are having a consistent bowel program, a consistent bladder hygiene, no skin issues, and then you get your bone scans every 2 years or so and make sure they are mobile. That's how you try to help these patients. Again, the treatment is too long. This is not pertinent to this talk. It's a syndrome, so you have to remove the actual cause. Like I said, usually it's a catheter. Obviously, you have to see the map, remove all the tight clothing, all the stuff. And then if you can close the catheter, you have to change the catheter. You have to catheterize first, obviously, and then think about UTIs and everything else going on with the patient. But this is a syndrome. So if you don't remove it, when I was in MedStar, Georgetown, one of my residents kept calling me at 2 in the morning, 3 in the morning, because he couldn't find the syndrome. It was like every half an hour, he was trying to figure it out. And I said, you have two solutions. Either you transfer the patient, you keep doing it until the patient die. And he transferred the patient. And he was, I think it was, we sent an abstract on this case. It was pleural effusion. So I said to him, you would never have found what it was. And like I said, it can happen anyway. Neurological changes happen to these patients as well, and not that common. About 12% you have sensory loss, motor loss. One thing that, and this is common things are common. If you have a paraplegic and you are doing this 300 times a day in your chair, you're going to have shoulder problems. We're going to talk about MSK, elbow problems, wrist problems. And then that's common, mononeuropathies, and you have to suspect that. But one thing that I want to talk to you about is the syrinx. Syrinx is not that common. It happens usually after years of having the injury. I have seen few earlier, and it can be a problem for these patients. If a patient come to you with a C7, which it means he can't do his tricep, he was independent, and he tell you, Dr. Castillo, I cannot transfer anymore, and then you can figure out it's not a mononeuropathy, and then he tell you my pain is worse and I lost sensory, that triggers an MRI right away. That should trigger your MRI right away because that is probably a syrinx, okay? So if you have a patient, loss of function is actually the last thing. First is sensory changes, pain in the area of the injury, and then loss of function. And that's a kind of emergency in a sense. Sometimes the surgeons just follow with MRIs yearly because they don't want to mess with this because sometimes it's difficult. But in general, that's something I want to make you aware so you know. And again, like I said, periodical assessments of sensory and functions will review systems on the nervous system. Again, just listen to your patients. And then you see a syrinx there, which is cervical, which is basically a fluid cyst, and then can extend and cause problems. Again, like I said, musculoskeletal, shoulder pain number one is you treat it the same as anybody. Surgery is the last resort because think about it. If you have a patient with spinal cord injury who's now is it depends on the hands. If you operate, they try not to as much as possible. I have a recent patient, a chronic patient, who had bilateral shoulders and ended up in a skilled nursing, and they came to us after that. But it's a big deal for them because that's their function, and they can lose their function, then they lose the ability to be independent. So you got to treat this aggressively, but surgery is the last resort. So again, like when they come to me with any type of pain in the shoulder, I'm very aggressive, trying to figure out injections, medications, therapy, because I know if you don't do something, it can be a problem. Osteoporosis and fractures, about 30% is in our patients. We know that the first year is the worst, and then plateau, and then continues to lose bone density yearly. It's a cumulative about 1% a year. So this patient, we usually order DEXA scans at the beginning, and then every so often. The guidelines talk about 2 years, but some people do it. Insurance don't let us do it sometimes. But it's a big deal too because they can have fractures, usually distal femur, proximal tibial pelvis. So you have to also have suspicious because if you have a patient with no sensory motor, they're not going to tell you when you have a fracture because they may not have pain. What they do is they have increased spasticity, right? And they have AD. They can go into AD, increase spasticity, and that's why you have to suspect. And sometimes spasticity, I ask him, when they have increased spasticity, I have to figure out why they have increased spasticity, why stable. So the fracture is a big deal, so you have to make sure that they have a vitamin D, calcium. And we have recently in 2017, 18, we have the guidelines that are pretty cool. And to when to recommend DEXAs, the guidelines for fractures, and wheelchair, etc. Pain. Big topic. This is a whole lecture by itself. It's poorly understood. Can happen immediately after an injury, may persist for life. This is one of the biggest challenges we have. Actually, the chart on the right, Illy, is from Dr. Anybody who knows about pain is Dr. Bryce. He writes all the articles for pain. He writes Bradham in pain. He writes he's the expert in pain, and he talks about if you want to learn pain, you're in the right place. So usually it's very complex to understand. Usually it's because the ischemia trauma, like I said to you, is an inflammatory process. You have your neurochemical and anatomical and all the cell changes that basically cause inflammation, has a physiological response, and then the clinical behavior of these patients. And that's the problem that you have here, that you have all these changes in different ways interacting, causing a behavioral response in these patients. And sometimes it's difficult. So you have the classification from Dr. Bryce, which is the type of the pain, the type of subtype, and the source. So you have nociceptive, neuropathic, other pain and unknown. And then nociceptive, you have MSK, visceral pain, and nociceptive pain. Neuropathic pain, you have above, at the level below, and other. That classification sometimes is really hard to use. When I test my residents, sometimes they confuse. So what I usually, it's easier to just say nociceptive, neuropathy, you just by the level. That's easier to classify like that. Because the reason why they did this, because we were having so many problems, because people who are sometimes incomplete, they can have nociceptive pain. So they can have at the levels, if you have sensor, you're going to have nociceptive pain. So that's why they had to change the classification so many times. Let's see. Again, you know, consider the earliest assessment of pain assessment. I mean, we have these assessments every day with our patients. The CAN pain, which is the Canadian Association for Pain, which is well known. It was released in 2016, I believe, and recently they did an update, 2020. They released guidelines on how to treat pain and how to basically follow up. They recommend interdisciplinary approach, which is what we do. Multimodal approach basically is using different type of medication for a different type of pain. If you have nociceptive pain, you treat that as well. Neuropathic pain, you treat that. But the guidelines talk about unfortunately, we don't have a lot of choices. The main one is pregabalin around the world. In the United States is Neurontin because of the cost. If you go to Italy, if you go to Colombia, I don't know in Canada. I don't know in Canada. But if you go to Italy, you go to France, you go to Colombia, they're going to use Lyrica first, and then Neurontin after that. For cost here is reverse. You use Neurontin and then Lyrica. But pregabalin is number one, and then you have gabapentin, and then TCH, which is amitriptyline, and that's exactly what I do with my patients. And then you have second line, which is tramadol, which is in Canada, it's called tramadont. The Canadians hate it. So tramadol or tramadont is call it with dirty drug, either work or doesn't work. If you try to work, keep it. If you try, it doesn't work, get it out. He has a lot of problems. Is a weak opioid as far as using it for strong pain, but it's safer than other ones, but it's not that useful. So, and then after, if you start reaching other medication, I usually send it to pain management because those medications, I have to do a lot of labs like LFT, stuff like that. And then you see the opioids have a role, but they are the last. In our book is the last, but a lot of people use it first. It's our last line of treatment. But unfortunately, as you know, there's a crisis, and we have a lot of issues with opioids in this country. But again, in my experience, people who actually are mobile, they're active, they can control the pain better. People who are not that active, have a lot of comorbidities, usually have more issues with pain, whether neuropathic or not neuropathic. This is something that I'm passionate about, which is the immune system, because I believe this is one of the biggest problems we have to trying to get these patients to live longer. And this, I think this is eventually going to be an autoimmune disease because these patients do not respond well to infections. And they develop a syndrome, immunodepressive syndrome at the beginning, when you have all the impairs on the response of the immune system, impaired bacterial phagocytosis, and diminish the immune system response, which is well known. And then, this is something that we are still investigating. We know that inflammation is part of the process. It happens to all of us, but in our patient, it's just constant inflammation, and it happens to the bladder, it has to do with colon, has to do with the lungs, and it's a big issue. So more research is needed. Actually, we have plenty of data about the cytokines, how the cytokines respond to the acute, subacute, and chronic, and we know how the cytokines respond chronically to these patients, and how all this I call it fire within of the body is really hard to ameliorate. So more research on that. But this is another reason why our patients have difficulty healing. And I hate with passion pressure injuries, because we used to call it pressure wounds. Now it's called pressure injuries because they believe it's more like injury than a wound. And the reason why I hate these wounds is because they basically disrupt this patient's life tremendously. And even though whether it's in Spanish and English and French, I talk to these people, it's hard for people to understand the magnitude of this issue. And we have people who come with wounds and get worse. I have to transfer because they have osteomyelitis, and it changes. This is a classification. So you have stage 1, which is basically a non-blanching erythema. There's stage 2, which is partial thickness. Stage 3, full thickness. Stage 4, full thickness down to the bone. Then you have unstageable, which is a scar tissue, scar. And then you have deep tissue injury, which is basically a bruise. The management of these wounds can be very, very, very complex, and they're very dynamic and very, very stressful. So you have a high incidence of these patients, unfortunately. A lot of your patients are going to have this. But in general, they are preventable. Just I feel sometimes that it's really hard to prevent. Spasticity is also a fascinating syndrome. Encompass the features of open motor neuron, including clonus, spasms, spastic contractions, weakness. And you can all see it at the same time or in different type of settings. It's basically a decreased inhibition from your spinal cord and increased excitation because there's no control. You have positive and negative signs of the syndrome. And the way you treat it, you don't have to treat it. Many patients, we don't treat it because even some people use it as a functional tool. Some people actually can stand with spasticity. Some people can use the spasticity and contractions to grab things. But when it affects function or patient have problems with pain and is severe enough, then you treat it. And usually go by the therapist and the patients as well. So how you treat it, you have different levels of treatment. You have step 1. Now, this day is more like longitudinal. Used to be a pyramid. Now you can treat the same thing at the same time. You have physical modalities. You have the therapist, stretching, splinting, casting, all that stuff that we do. Then you can use a lot of medications. You have the baclofen, you have the tizanidine, you have the dantrolene, all those medications that we have, as well as Valium, which I don't use as much. And then you have chemodilatation, Botox, Xeomin, which is underutilized in the United States by doctors, but they're very good as well. So everything is to help function, to trying to figure it out. So you can use the medications alone. You can use the medications with the injections. You can use the medications with injections and the physical modalities. You can use everything together. You can use one. Nowadays, it's more dynamic and more varied. And then you have the intrathecal baclofen, which is, to me, is last resource. And you ask that at the end when people have reached the ceiling of the baclofen or the dantrolene and the tizanidine, and you can't control the spasticity, and then goes into AD. I have patients who spasticity throw them out of the chair or the bed. That's a no-no. So those cases all develop contractures. You don't want that. So those things you have to make sure that are preventable. And that's why, you go by steps and you try to figure out how to treat this patient holistically. And then if you offer a baclofen pump, remember you're the ones going to manage it. And majority of these cases, the problem is the catheter. So for most of my patients do very well with this, except when they're not. And it's fun to figure out where is the problem. And then if they go to the local ER, they always blame the pump. And they call me and your baclofen is not working. I say, no, try to figure out first is the bowel, the bladder, the skin. But they always want to blame the pump. So the pump, if you want to play the pump, just make sure that, remember that you are the one responsible for the pump. Woman ACI is a topic that is not being studied a lot. It's about 20% of the population for all of these spinal cord injuries. It's being much more. My partner, Dr. Romale, which has been here for 8 months, she's passionate about this, about woman ACI. We have published recently in PM&R clinics in North America, several articles about woman in ACI because it's important. So there are 45,000 patients prevalence, which is much lower than in general. You have 300,000 people living with this disease. Usually also motor vehicle accidents, obviously. But it can affect everything. It's a different population. It's a top by itself. Either the gynecologic aspect of this, obstetric is a huge one. There are not many pregnant spinal cord patients, but I tell you, I've treated plenty already that I feel I have three patients with pregnancy and baclofen pump. I asked Medtronic to send me all the articles about baclofen pump and pregnancy, and they send me case reports, which are not strong. What I learned is the dose. Even though it's micrograms instead of milligrams, it appears that decreasing, keeping the low dose in these patients during the pregnancy helps to prevent problems with the baby. So that I learned from that, as well as the management of the bladder, things like that. We have patients with as the baby grows in the belly, you're gonna have problems with either AD, spasticity, or even UTIs and frequent urinary frequency. Sorry, and I have two approaches of this for my patients. One, refuse a Foley as the baby was growing. She wanted more catheters, so we gave her more catheters. So we're just cutting every 2 hours because she didn't want a Foley. And until the end, we had to put a Foley and put antibiotics on her. And the other one wanted a Foley right away. So okay, we're a Foley. Yeah. So again, you have to listen to your patients what they want, and remember, happy mom, happy baby. So give the mom what they want so they can have a happy baby. Okay, very important. Again, we talk about this. One thing that I stop talking to patients is because of the hormonal changes at the top of the injury, majority have the menstrual period basically halted. And I have a young girl who told her that she's not going to have it. The next day she had it, she was mad. So when I said now is they could not come for, because it's true, it can lose their menstrual period for up to 6 months. But like in this girl, it came back right away. So during that period, they don't have the menstrual period. That doesn't mean they don't get pregnant. They can get pregnant. So I usually tell them you could get pregnant even because that is a hormonal issue, but you still can get pregnant within that period of time. So they have to basically also be careful with that. Sexuality is a big issue. I usually sit down with them. I have a talk for males, I talk for females, because obviously we have to address both issues. So it affects everything. We have to talk about lack of knowledge. I usually ask them, the way I approach this, I think it's an article from Dr. Kirschbaum, can't remember, from the 2000s, talking about this, how you do it. I usually share with my residents, basically you talk the same way you do it with cancer patients. The person who knows the most talks first. You ask the person how much they know, in an environment that is obviously privacy. And you ask them how much they know, and then you start explaining the process of why spinal cord injury affects sexuality. And it can affect everything from lubrication to sensation to desire. So I usually ask the patients to understand their body after the injury, make sure they do a lot of foreplay and trying to find areas where they have sensory sensation. I have a whole talk about this. But it is doable as long as the patient, the partner, are willing to try. Let's see. Well, we'll talk about sexuality already, how this is affected, and then aging. Everybody wants independence. The main concern of people with spinal cord as they age is keep their health, remain independent is a huge one, and satisfying life, right? And how this is some data about when people need assistance for tetraplegia 49, for paraplegia 54. So obviously, as they different than us, so to keep in mind that these people will need help, and the early interventions are better. So always talk to the patients and what they need, just try to help them right away so they can keep the independence. The stress and depression and perceive about quality of life is important because change is independent. Everybody wants independent. I usually tell them that. I said, I know you want your independence, but it's the hardest thing for people is to ask for help. That's the hardest thing for people. They want to be independent and want to ask for help. And unfortunately, in this case, you have. And we know that it's funny because I asked my residents how many what is the incidence of depression? They say, oh, it's 80%. Not true, it's about 30%. So a lot of people they don't have depression, they have grievance. So they grieve first, and as they evolve, actually people adapt. And it's our perception as the providers what is worse than the injury itself, because we don't want that for us. So we catastrophize, oh my God, that's terrible. But in their life, they adapt. People adapt with this injury and do fine. If you will read the last, which is published in the book I edited last month, with about the perception of patients' spinal cord injuries, yes, they'll want to walk, but in reality, what they want is bladder, bowel, sex, hands. So if they can't walk, then obviously they want something make them more functional, and that's fair, right? So in general, it's more our perception than the reality of the injury. These people can thrive with environment. The problem is how we make the environment difficult for them. Okay, so think about that when you talk to your patients about depression and stress. Resiliency. We know that Debbie Downers before the injury are gonna do worse. If you are a person who were not positive alive before the injury and you got an injury, is we know from studies from the VA that you're not gonna do well. People have look about life, they're pretty gung-ho, and they have this type of injury. I have people who go back to work right away, and I want to do this, and this is not gonna stop me. A young, old guy, a few weeks ago, and he impressed me. He was like, "Let's go, let's do this," and he was just, I was not expecting that, and he impressed me. So sometimes you don't know, but you're gonna see, the whole point is you're gonna see people in front of you. Don't make assumptions. Don't make assumptions that this person, oh, this person gonna be terrible. You don't know. You don't know. Just try. This is why you are the one in training. You are the one who knows. But also work with that person because this is a very devastating injury, and the lives ups and down, and you have the knowledge. This is a picture when we went to Argentina, sorry. And the guy you see there in the chair is a physiatrist. He's a physiatrist from Costa Rica, and he travels everywhere. And I asked him, how you keep yourself healthy? He's in his 70s. He said, I don't know, I just move around. And he only had like a shoulder pain. That's all he has. This guy go all over the world. And he's a paraplegic, very functional. The greater the participation is, the better. Our bodies are not designed to be in a bed. You have to move. Our bodies are not designed not to be where human beings we cannot be in isolation. So that's another thing that you have to understand. Community is extremely important. And in Latino communities, well, it's a double sword, because in Latino communities you have the problem with biases and stereotypes, and if you are disabled, you're crippled basically, and they put you. That's changing, but basically that's what it is. Here is more integrative, but then you're isolated. In our culture, family is important. They will protect you. They will, but it also, when I was in Washington, D.C., I noticed that in Latino community, when they have an injury, they all wanted to feed him and they wanted to do this. I said, no. He has to learn how to do everything. He has to. So that was a problem, trying to convince him to let him do everything independently. And I'm sure you guys, big cities like New York, you're going to see that a lot. So you keep in mind that sometimes you have to use tough love to make sure these patients go through the whole process. And then again, family is important. We talk about that. Ensure that people living with injuries are properly educated so that they advocate for themselves. Huge. I give them a lot of resources. But I did a small non-scientific research with one of my residents here, and we started doing what every single hospital does in the United States, rehabilitation, which is education, right? Which is very important. We found the education we do sometimes doesn't work because these people, we're humans. I mean, you have an injury. If you've ever been to a doctor and you're sitting there with a physician for less than 20 minutes or half an hour, and they tell you bad news, you're shocked. You're going to be blocked. And that's going to last for a while. The same happened to these patients. So throwing all that to the patient at once is not going to be beneficial. And this is what sometimes we do. We give them a basket of things and, oh, read that. And we expect them to all do that stuff, and they're not going to do that. So we learned that it's better to do drip, 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 drip. small piece of information. So every Tuesday, what we do here, we round and we see every single patient with the whole team every Tuesday or every Friday. After the team meeting, we round together and we tell them, this is where you are, this is what happened to you, blah, blah, blah. And I tell them, just ask me the questions every day. If you want to understand your injury, just ask me. And they ask me every week. It's very overwhelming. So we do that. We learn that it's better to give it in dosages. It's drip, 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 drip. You want the information when you need it, not when you think the provider think the patient's gonna need it. And I think that's better. Again, how everything is integrating and how do you educate basically. And it's important to have a program where it's focused on the patient basically. And this is the secret weapon that we have in every single hospital in the United States, which is the doctor, rehab nurses, the speech therapists, everybody else. And this is what makes hospitals like ours, hospital rehabilitation different. This is what the beauty of physiatry is to me. I would not do anything else different because this is, I believe, is one of the best specialties in the world. Not biased, but I think that we make a difference, and it's because of the people we work with, and the family, obviously. We talk about that. These are resources you can use from Asia. These are were designed for primary care providers, but I use it for my residents as well because it's if you go to this website, it's free. You can download it and you see the annual health maintenance and episodic care. You don't miss anything. My residents complain that it's just a lot of information, but it's actually useful because it tells you every time a patient comes, you are not going to miss anything on your patient because you're going to ask the same thing every time. Bowel, bladder, skin, health. It's very good. It's very well done. It's done by us, by Asia. We released this a few years ago. And it's pretty good. So if you want to learn more, you can use the topics. The articles are also free and in Spanish because we translated them in Spanish. And we use them, we give it to people in Latin America. Again, they don't have resources. By the way, residents in Latin America, they are self-driven. They don't have the structure you guys have here. They have to find their resources themselves. And the average training for spinal cord injury in Latin America is about less than a month for spinal cord injury. They don't have a lot of exposure to this. It's changing thanks to everything we're doing. So we went there, we deliver a lot of information, and we're changing the way that these patients are treated in Latin America. And the articles are all in Spanish as well, if you want to read them in Spanish. And they are very simple to read. They're very good. And it's a very good resource. This is the thing you're going to see in those articles, in those forms. You can print it. I have them in my office, and I give it to my residents when they're going to see a patient. I said, just ask these questions. And they do. And they are very useful. I like them. And again, my last pitch is for Spinal Cord Injury Fellowship. We have 20-something fellowships every year. We hope that people apply more and more. We need more spinal cord doctors. We really need more spinal cord doctors because none of us are getting any younger. And these patients need specialized care, and people don't realize that. If you rotate for spinal cord injury, you will find the difference. And when you leave the unit, you're gonna notice the difference because it is a different approach about these patients and how they are treated and how they are seen. Okay, so if you want to do a spinal cord injury fellowship, I have one here. You can apply after the residence. And again, like I said, spinal cord injury is not the end of a life; it's the beginning of a new one. And it's a change. It can change people's life instantly. This is not my quote, but I use it because I like it a lot, because it's true. It's not the end. It's just the beginning. And if they take it that way, it would be better for them and also for the people around them. And this is my team. All right. Any questions?
I guess I have one question. So what would you say is the biggest challenge right now when it comes to spinal cord injury? Oh, and then there's another question in the chat.
Oh, hold on, because you guys, I don't know where you guys go. Hold on, where's mine? Are you here? Oh, you got mine. Man, I'm kind of illiterate with this thing. Where's the question? The chat, you said? Oh, can you tell us a little about your involvement with Asia America? Oh yeah, yeah, absolutely. Anybody can get involved. If you speak, now you have to be member of Asia. The committee is led by Dr. I was the founder, and then I left and I became a member, a board member. And then Dr. Hernandez, which is from Mexico, is the president, or the chair, sorry. And Dr. Melina Longoni, which is from Argentina, but she lived in Spain, in Madrid. She's the vice chair. I can put you in contact with them. We meet, I think every 3 months, and then we discuss plans, what we're doing. They do a lot of educational online. They do a lot of training online for people, doctors in spinal cord injury. And then we travel too. We have been in Ecuador, Bolivia, Uruguay, Peru. We're going to Argentina again this year, Honduras next year, Mexico the year after. So we partner with AMLAR. AMLAR is the largest rehab association in Latin America of physiatrists, and then we manage the spinal cord section of them. So every time they go, which is every 2 years, and move from country to country, then we go and do the whole section of spinal cord injury for them. Last year, or this year, no, last year was in Peru, and we did the whole lecture in spinal cord injury for them in Peru. In 2 years, or next year, is going to be either Honduras or Mexico, and then we do that as well for them. But we also do other courses in Latin America to enhance that. If you want to be involved, you have to be a member of Asia. I can put you in contact if you want with the people who can get you in, and then you have to be part of the committee and be involved. Otherwise, they kick you out. I'm kidding. All right. Any other questions? So let me know if
Yeah.
you want.
Mm,
Go ahead.
okay.
If you speak Spanish, better though, because if you Spanish, obviously that helps you to go into, because the hardest part of Latin America is the translation, because we used that before, and I didn't know that it's so expensive for them to pay translators or have translation systems. So if you speak Spanish and you want to do presentation in Spanish, that's huge because they don't have to worry about that. Go ahead, Ellie.
Yes, my question was, what do you think is the biggest challenge right now in spinal cord injury, or that you see in the next like 5, 10 years if we don't,
Oh
work
gosh.
on it now?
There are multiple challenges. The main challenge I see now is one is insurance. Um, they are cutting a lot of the services and fighting us for everything. Bringing patient, I mean, like a lot of hospitals like mine bring patients sometimes twice, and it's appropriate, two-step. So you discharge the patient, and then you let the patient go home, and then for any reason you come back. It's completely appropriate. They don't want that anymore. So they are cutting, and it's affecting our outcomes, right? So it's very stressful to work the system sometimes. That's one of the biggest things that we have. The second thing that we have a problem is the lack of physicians that we have caring for the patients. That's another one that's really concerning, that we're hoping is just because it fluctuates. Sometimes we have a lot of candidates, but last year was terrible. We didn't have enough. Half of the spots were on field, and we were concerned because I understand. I live in Kentucky. People want to live in New York. People want to be in Texas. I understand. Geographically, I get that I'm in a very tough position. But for tier or for Washington State, for not to match, it was concerning because they are like Washington University is the mecca. I mean, they have Dr. Byrne, they have Dr. Jelena. You have a lot of people there who have done this for years, and everybody knows them, and they didn't match. And the same with tier, where they have a physiatrist only do spinal cord injury, and they didn't match either. So it's kind of concerning that we're not getting enough doctors interested in this, and we don't know exactly why it is. We have some suspicions, but we don't know why. So we are submitting courses and we're doing all this to try to make people aware of the excitement of this field and how good it can be at this field. I don't think people know how great this field is. So that's the other challenge. The third challenge we have is technology. What's going to be the next thing for these patients? Because technology in rehabilitation is challenging. Standard of care for rehab is overseen by CARF, which is the association that regulates all rehab units. However, not everybody pays for CARF. And like Shirley Ryan is one of the best hospitals in rehabilitation. I don't think we have CARF. We have CARF, but there's now companies who are for profit, who are a lot of rehab units, open a lot of rehab units in the United States, and they only do inpatient. And these patients are discharged, in many cases, no follow-up. So you have follow-up, no follow-up, and no physiatry following these patients. So technology, we're figuring out how technology is going to play a role in this, whether it is applying for, like telehealth, AI. I love AI. I don't know AI is going to change the field of rehabilitation, but I think well-regulated technology will help us as well. I just don't know how. But we need to figure out how we get more awareness of people's spinal cord injury, how we become better advocates for them. The other problem we have is we don't have another Christopher Reeve. I don't know, you guys don't know who Christopher Reeve is because you guys too young in this talk, but that's the original Superman, by the way. So Christopher Reeve, when he died, he was the face of, and he just released his children just released a documentary watch, which is fascinating about his story. If you can watch it, you watch it. I think it's HBO. But the point is that we don't have a face now for spinal cord injury like used to be. So brain injury, they spend a lot of money. They have this mapping DNA thing. We don't have anything. So we are struggling trying to get our field up because we know our patients need it. So those are the challenges we're seeing because many hospitals are popping up as a rehab units, but they claim to treat these patients, and I don't know if they do. So it's a lot of layers of your questions. That's a
Okay,
good
no,
question.
yeah, thank you for that. Does anyone else have any questions?
Nobody has questions? Come
I have a
on.
question.
Who's Vanessa?
Yes, hello. Thank you for your wonderful presentation.
Where are you from? Vanessa Molina. That has to
Yes,
be Spanish.
I am in Texas. I go to Sam Houston.
Oh, nice.
Yes, I'm a
Good.
third year currently.
Awesome. Which school you go to?
Sam Houston, it's in Conroe, a little bit north of Houston.
Houston. Houston is a huge city.
Yes, giant.
West
All my
Coast.
rotations are very, very spread out right now.
I know. I went to I thought it was in downtown. It's just the hospital area. You have like two
Oh, yeah.
downtowns. It's crazy.
Yeah.
Okay, sorry.
Everybody says, no, no worries. People say that a lot. They'll be like, oh, you downtown, and I'm like, the medical center or downtown,
I
or
know.
something
I
else.
know. I was like, oh my God, this is huge. All right. What's your
Yeah.
question, man?
My question is regarding autonomic dysreflexia. So I know you were mentioning some of the more predominant causes of it, but if you can't figure it out, let's say, how do you go about, like, I guess all the diagnostic tests and imaging so that you are not doing any excessive testing to kind of figure out what the cause might be once you've kind of are getting near exhausting your list of possibilities?
That's a great question. Just remember that AD is a syndrome, right? So something is causing the problem. So if you see yourself now, there's people who have acute AD and there's people who have chronic AD, like blood pressure goes up, and we try to figure it out. So when you have patients who you can't figure out what's going on, you have to treat it. So that's when you have to probably give some type of medication for them to keep all the time. So we use the natropase, which, by the way, I didn't know this. Canada doesn't have it, and Latin America don't have it, which is we have it usually here. Natropase, you put It's about a vasodilator, and we give it to our patients at home, and we're training how to use it carefully. Because you're right, sometimes they can't figure out they have to go to the ER and they have to do the workup. In the case I just described, I knew it was the bowels, but the hospitals were not dismissing, but they were trying to downplay the issue of the bowel. They wanted to do MRIs, which they did. But again, to answer your question, Vanessa, is also a high level of suspicious and experience, because you're gonna be seeing these patients over and over and over and over and over. And you got to figure out, okay, is it the bowel, is it the bladder, is it the skin? Okay. If it's not that, then you have to do a CT. You have to figure out if it's the abdomen, if it's the kidneys. Sometimes kidney stone can cause this. But the most part is a syndrome. So usually 90% of the time is the bladder, and then the bowel and the skin. That's where you have to start right away. If you can't figure it out, then you have to, if it's 150 milligrams of mercury, it's high 20 from baseline, then you have to use natural-based. And if you can't, you have to keep it oral medications. You have to be careful. Sometimes it drops the blood pressure too fast. But it's a syndrome, so you have to figure out what it is. And usually, most of the time, you figure out what it is. Because experience-wise, and because it's below the level injury, it's a hollow viscous, either the bowel and the bladder who cause the problem because of the C fibers and the presynaptic neurons that I explained to you.
Thank you.
That was a good question. Any other good questions?
Hi, Dr.
Matthew, your name doesn't sound Hispanic.
No, I'm actually Indian, but